Great. Welcome, everybody, to this forum on the Delivery System Reform Incentive Payment Program and version 2.0. What should it look like in California going forward? And we have a really terrific agenda today, and excited to be offering this up for you and for discussion. In addition to those that we have here in the room, we are webcasting it, so we have people participating by webinar as well. And transformation is certainly in the air, as it is, I suppose, every 5 years when it comes time to renew the state's Medicaid waiver. I don't know that it's always been that case. I think for many years there were many of us who saw the waivers come and go and thought, what has changed? But I'm pretty confident we're no longer saying that anymore after this last waiver. I've been thinking a lot about transformation recently. Part of it is the season, transforming our house for the holidays. Our children transform in anticipation of Santa coming. And then there's the New Year's resolutions. And the hard thing about any of those transformations is making them stick. It's not far into January that I think the decorations go away, the children are back to normal, the weight or other behavioral conditions have returned back to normal. But that can't be said of the impact of the DSRIP in California the past five years. It really has been transformational, and I know many of you work in hospitals, in public hospitals, or have spoken with leaders in public hospitals or consumers who use public hospitals, and really see the transformational change that's taking place there in terms of not just one or two quality improvement, process improvement projects, but really a groundswell of culture change in the system. And so we're here today to talk about how to build upon that. And there are certainly lots of ideas. We know that we're having this meeting in the context of a waiver work group that's working on the DSRIP. Their second meeting is Friday. That's a small group of very knowledgeable folks that are putting thought to that. There are public comment periods, but we really wanted to open up the conversation to a broader group and do something that, frankly, is much more difficult in the context of those waiver work groups, which is invite some leading thinkers and doers from other states to share their experiences and their models and their approaches and their successes and challenges that they've encountered, and give you the opportunity to engage with them in discussion about what's working and how what lessons we can draw for California. I was talking with Tom from Massachusetts, and he mentioned that in the development of their DSRIP program, DSRIP-like program, they borrowed heavily from California's. I'm more used to California taking great ideas from Massachusetts, so it's great to see a give and take here, and here we are back again. So I hope we'll learn a lot. I'm sure we'll learn a lot from the experiences of New York and Massachusetts and Texas here today. Lots of ideas, and I think if there's one sort of somber note, it's the news that California wasn't awarded the SIM grant. The $3 million planning, additional planning funds. Hopefully, we can use that to develop the ideas further. But it was a disappointment. I think we're all taking a breath and saying, which of these ideas can we move forward? Certainly at the California Healthcare Foundation, there were many ideas in there that are things that we've been working on. We will continue to work on. So we're asking ourselves and asking our partners how we can move some of these ideas forward. I know the other foundations are doing the same. But one place that people are looking is this DSRIP. How can we advance some of those ideas through the Medicaid waiver, and in particularly through this Delivery System Reform Incentive Pool, the accountable care communities, for example. There are lots of difficult, complex, interesting choices that we'll have to make in this next round of the DSRIP. Does it continue to be primarily a public hospital play, or do we expand this to include more hospitals? Do we do as some states have and make this really about community transformation and reach beyond the hospitals and really require some forging of partnerships with community organizations, whether that's on the ambulatory side or in some cases long-term care or social services side? What are the areas of focus? There's still lots of questions about, what should the aims be and where should we focus? Is it on integration? Is it care transitions? Is it high utilizers? Is it all the above? And the particularly complex issue of the source of funds. I think that's been clearly one of the sticking points here in California is that's been the reason why this is primarily a public hospital play is on the source of funds and the lack of general fund support for the DSRIP. But I know there are other ideas, and I think we can also learn from other states about how they've approached this. Every state is unique, of course. We can't, wouldn't want to or can't adopt in whole part what other states are doing, but I think we can certainly learn from their experiences. We have a terrific agenda, and I'm just going to quickly walk through the packet before I hand things off to Toby for what may be one of his last presentations. We don't know. We're all waiting with bated breath to find out, but we're excited to have him here today. We've got David Lown from the Safety Net Institute is going to do an overview of the Delivery System Reform Incentive Pool. We know that many of you know lots about the DSRIP, but some of you don't know as much, and so this is an opportunity to sort of bring everybody up to some fundamental knowledge so that we can have this broader conversation and ask some thoughtful questions. And then Peter Harbridge is going to facilitate a really terrific panel. Dr. Nirav Shah here now from Kaiser, so we're glad to have him here in the state working with us. Tom Traylor from Massachusetts and Billy Milby, who's now with Sellers Dorsey from the state of Texas to join us and share their expertise. We're going to take a quick lunch break, and then we're going to have a California panel and have some of our Lisa Chan from Harbridge Consulting is going to facilitate a session starting out with Dr. Neil Kahatsu and Erica Murray are going to talk about the DSRIP going forward and their perspectives and visions. And then a really terrific reactor panel of Dr. Mitch Katz, Bill Barcelona, Terry Leach, and we have Cindy Enos pinch hitting for Alan Miller. So thanks, Cindy, for doing that. It's great to have you here. And then we're going to wrap up with Richard Thomason, and that's a reminder to me that this is really a joint effort, and I want to thank, first of all, the folks at Harbridge Consulting for working with us and pulling this together, and Ingrid Aguirre-Happold as well, and our partners, the Department of Healthcare Services, in co-sponsoring this, and the Blue Shield of California Foundation. So thanks to our partners in working with us on this convening. So without further ado, I hope you're excited about this conversation, and please do, as the day goes along, get your questions ready, because we really do want this to be, we've left a lot of time for Q&A. We know you're not used to that, and we often get criticized for it, so we will have lots of time for Q&A, so please have your questions ready, and let's get started. So starting with Toby. Thanks.
Good morning, everyone. It's a pleasure to be here. First, I just wanted to, again, big thanks to the California Healthcare Foundation, to Blue Shield, and Harbridge Consulting for the work on bringing everyone together on this really important topic. So, as Chris said, a really big point here is this waiver has been very different than previous waivers. We've always come up together on waivers on how do we revenue maximize federal funding, what do we do to continue to shore up the public safety net. Well, we went forward in 2010 with a very different focus, working with our public hospitals and CMS in partnership. We went forward with the Delivery System Reform Incentive Pool with a concept that we wanted to focus on how do we both continue to stabilize the safety net in advance of healthcare reform, but how do we incentivize? How do we incentivize with payments to transform the delivery of care, to continue to push better quality and better outcomes? And really, that's where we have evolved with the Delivery System Reform Incentive Pool. And it has pushed the envelope, and we're going to talk today about how we take it farther. But what I wanted to first touch on, there is a lot of undercurrent out there, both California, but I'd say nationally, that we put a lot in California into our DSRIP, and we've gotten modest return. And I would say that's just not true, that we really did push with this 2010 waiver with DSRIP. really advanced better quality and better outcomes. And you're going to hear today a lot about that from our colleagues at CAPH and my colleagues within the department. But it has already had meaningful impact within our public hospital system. And those are players, they're actors that within the overall safety net are serving 40% of the uninsured. That huge impact within the delivery system. And some of, just as note, some of the actions that we've seen is, for example, Kern Medical Center. We saw a 61% reduction in ED visits and 66% reduction in avoidable inpatient admissions. And Alameda Health System, they created a complex care program that resulted in focusing on the top 5% of their overall utilizers of healthcare and reduced care by 20% for ED and 23% for hospital admissions. Huge, huge impacts. And this is just examples. But the other piece of this is just the culture. And Chris talked about this, the culture of quality. This is extremely complicated work to bring together systems of care. And pushing that culture of quality helps advance where we need to go with DSRIP 2.0. And clearly we're going to have to push, we collectively, to take it to the next level. When you're going to hear from our colleagues in other states that they've had, CMS has pushed in that way, and we expect fully that we're going to have goals that are really, really going to stretch our systems. And there is this embedded, starting place now with culture of quality that's going on both throughout the system that's going to help advance that. And as we look to better integrated care, or we look at ways to reduce misuse and overuse, very key components of our next 1115 way, patient-centered, whole-person care, these are going to be important elements. And so I hope today you learn a lot both about where we've been and where we're going to go to keep on advancing quality within the context of 1115 waiver. That no more is going to be just about bringing down federal funds for the sake of federal funds, but really about how do we advance the core of this, better patient-centered care and better outcomes. So thank you.
Good morning, everyone. Open up my slides here. So my name is Dr. David Lown. I'm the Chief Medical Officer for the California Healthcare Safety Net Institute, which is the performance improvement affiliate of the California Association of Public Hospitals and Health Systems. If everyone could say that with me together. Okay. So what I'm going to do is provide just a brief overview of the public healthcare systems of California, history of the DSRIP, and the structure of the DSRIP. And I thought I would start out, since you're still awake, by going through page by page the 479 pages of the standard terms and conditions, and we'll go from there. So what I'd like to do is really say that this, as Toby was talking about, that the DSRIP is a 5-year demonstration project really to enhance the systems of care, increase the integration of the public healthcare systems, and really ready them for the Affordable Care Act. And that really was part of what the Obama administration was seeing, and the administration here was this was preparation for the implementation of the PPACA, as some folks remember to say that. So this involved 17 different systems, and I'll talk about those in a second, plans for each of those across 21 different hospitals. So this is the overview of the membership of the California Association of Public Hospitals and Healthcare Systems, which are the 21 county-owned and operated healthcare systems and the 5 University of California medical centers. As was referenced before, while it's only a small number of hospitals, only about, I think about 6% of the total hospitals in California, we provide care for 40% of uninsured care in the hospital, train almost 60% of the new physicians in the state, provide crucial services such as burn and trauma, and cover almost 3 million patients. And these are systems of care. I know we tend to refer to them as public hospitals, but these are complete systems. Everything from emergency department and inpatient care to primary care, specialty care, the whole gamut. And really this is about creating, helping them transform to high-performing integrated systems. So a little history of the DSRIP. So coming into 2010, there were pre-existing scenarios that set us up for how the DSRIP came to be. And so starting with the 2005 waiver, in which there was significant change in the funding for the public healthcare systems, namely that prior to 2005, the public healthcare systems were receiving some general fund from the state for the Medi-Cal uninsured. And 2005 shifted that so that the public healthcare systems were now paying the non-federal share for all Medi-Cal and uninsured fee-for-service payments. And the amount of dollars available from the feds was actually capped. And the public healthcare systems were actually reaching those caps pretty early on. Now, there was a little bit of a bump through the shift in the federal match through the ERA, through the Recovery Act, and that helped the public healthcare systems, but it certainly didn't fill the gap. And as the slide notes, the Obama administration recognized the vast underfunding of the public healthcare systems, and at the same time knowing that we couldn't just continue to provide straight subsidies and wanting to shift to more value-based incentive program. So these dollars were shifting into this incentive program. So, as I mentioned, the DSRIP has involved 17 different systems, 21 different hospitals. Each of those involved in a myriad of improvement initiatives. As it says here, up to 15, on average, about 15 projects per system. And each project has milestones that need to be achieved. And you know, our systems were doing upwards of 200 plus milestones each year of transformative work in order to receive this funding. In order to get the funding, really needed to make significant achievements on your own without any dollars up front. So the health systems had to complete the milestones, actually provide this IGT, the intergovernmental transfer first, and then receive this funding, which is this 50 cents on the dollar that we were talking about with the federal, non-federal share being provided by the healthcare systems. The other important thing to remember is that as the DSRIP was being developed, this was the first one in the country. So CMS was figuring it out as we went along. And I would think it took 6 months or so of the first year just to figure out some of the specific terms of what was going to happen, what the rules of the road. So as other folks have said about other transformation efforts, it's really changing the tires on the cars that's going 60 miles down the highway. And I think as we see from other states, CMS is still figuring it out. And that's significant. So lastly, I said it would be brief. So lastly, the DSRIP structure overall is 5 different categories. It actually started with just 4 categories. First category being infrastructure and development, and that really focused on increasing the capacity, either physical capacity or staffing capacity of primary care sites, of implementing chronic disease registries and the like. Category 2, innovation and redesign. For many of our systems, this was about implementing patient-centered medical homes, developing integrative behavioral health programs, increasing the amount of interpreter services, so really redesigning how the care is provided. Category 3 was building the capacity for reporting on 4 different categories of care. So one was preventive health, so reporting on provision of flu shots, cancer screening, tobacco cessation and the like, chronic disease care, so diabetes control, hypertension control, asthma, care coordination, admissions for chronic pulmonary disease and heart failure, and then 4 was patient experience. So all the systems, all the public healthcare systems began uniformly reporting on what's called CG-CAPS, a measure of patient experience. Now, Category 3 wasn't charged with improvements, but it was charged with building the capacity to report uniformly across all these systems, and that had not happened previously in California healthcare systems. Category 4, urgent improvements in care focused on patient safety in the inpatient setting. All systems were required to implement projects improving central line central line associated blood system infections and sepsis, and then had options to improve on other things such as stroke or falls. And again, huge initiatives and huge ability to coordinate improvement initiatives in the inpatient setting. Lastly, Category 5. Category 5 was instituted in order to help transition the Ryan White and HIV persons with AIDS patients into the Medi-Cal system as the ACA was implemented, and incorporate those folks into the public healthcare systems. So I'm going to sum up just by saying that while this is the last year of this waiver, this DSRIP, this is really just the beginning of a much longer journey. As we know from other high-performing healthcare systems around the country, this is not a 5-year journey. It's not even a 10-year journey. This is a 15 to 20-year transformative journey. And even those who are at the 12 and 15-year stages, they still say they have a lot of work to do. And so we are certainly just beginning that transformation path. So I'm open for questions. Hopefully I've covered every detail of the DSRIP you could possibly think of. Okay. Chris.
I want to model the behavior that we're looking for in terms of questions. So, David, before you were with the improvement arm of the California Station of Public Hospitals and Health Systems called the Safety Net Institute. Was that good enough?
That's pretty good.
Yeah. You were with the, I believe you were with the Community Clinic Association in San Francisco. Sure. And I'm wondering sort of if you can reflect back on that experience. What was your view of DSRIP at the time, or how were your members then seeing the DSRIP, and how did it play out for them?
Good question. So at the time, the DSRIP was mostly the initiative, well, it was the initiative of the San Francisco, now called San Francisco Health Network. And the individual community clinics were not specifically involved. Although I'd say that initiatives that were going on at the San Francisco, at the General Hospital and the clinics therein, there was related work that was going on with the community clinics. For example, there was Kaiser-sponsored specialty care initiative, and then Blue Shield actually sponsored specialty care initiative. And I think that directly related to some of the DSRIP projects. So while the DSRIP itself was the province of the San Francisco Department of Public Health Network, and the community clinics probably were not that aware of the specifics of the program, there were programs that were still being, improvement initiatives that were being shared across those entities. And also relates to the environment that exists in San Francisco long before the DSRIP, which is a very collaborative nature between the community health centers and the public.
Hold on, Terry, one sec. We have a webcast, so we can't talk without the mic, or the folks at home can't hear us.
Thanks. Can you share with us how much of the incentive payments have been received by the participating hospitals thus far? Or about?
4 out of the 5 years.
Yes.
I'm not sure. I don't have those figures. I mean, in terms of specific dollar amounts, or I don't have those figures off the top of my head. We can certainly get them and make them available.
Okay.
I can have those for you in like 5 minutes. Yeah.
Oh, there you go, Tiana.
Okay.
I think we had over here.
Thank you very much. I wanted to ask, how have the public hospitals and the Safety Net Institute addressed issues around sustainability of the changes and the efforts that have been made? I mean, how have they been able to be embedded into practice as opposed to being things that, you know, if the dollars aren't there to support them, end up drying up over time? So how has that been addressed?
I would say that I think that varies across the entities, depending on how the local support system is structured for the public hospital system. But I would say that for the majority of our members, they don't see these changes as, oh, we'll make the changes now because the DSRIP is here, and then we can go back to what we were doing before. I mean, they see the writing on the wall that these changes in infrastructure and organization and integration are necessary for survival beyond the DSRIP. To thrive sort of in two realms. One is to be a provider of choice and to continue to serve the mission of serve the uninsured. In order to do, and both of those feed off each other, certainly. You can't serve your mission if you can't keep the doors open. And being high-performing systems of integrated care and having these sustainable changes is absolutely necessary to keep functioning. So they are embedding those changes within their organizational structures.
Hi. You mentioned that for the systems to get the incentive funding that they had some milestones that they needed to achieve. Can you explain what are examples of some of the milestones that needed to be achieved?
Sure. Just off the top of my head. So, for example, an integration of behavioral health may be a project, but within that there will be a number of milestones underneath it. Could be the number of people trained in terms of a new model of care, systems for coordinating the behavioral health with the physical health within the clinic, number of warm handoffs provided, but then maybe also some outcomes in terms of related to the number of patients who are receiving certain screenings and then being referred. So under each project, there are numerous milestones, and that's why we got to like 15 projects on average with upwards of 200 plus milestones. And in order to, you need to actually reach your target, and there were targets for each of those milestones, in order to reach your target in order to get those dollars. Tiana. Oh, you have those numbers. Go ahead.
I have the number, yeah. We're going to go here and here and then
Sorry. Okay, so to date, if you look at just the federal funds, we're about, well, over $2.6 billion paid out thus far. So that's with, we've begun our final year of the demonstration. So we have a bit left, but much of it's been paid out already.
And that's Tiana Morgan, District Coordinator at the Office of Medical Director at CHCF. Thank you.
So on the whole health behavioral integration with mental health and substance abuse services, can you give some examples of the current DSRIP structure in which those behavioral, the mental health and substance abuse integration projects have been particularly successful?
So I'll give one example, which is San Mateo Med Center, which has implemented the integration of behavioral health in a way that has allowed them to screen, and I don't have off the top of my head the numbers, but a high percentage of their diabetics in their integrated coordinated care clinic with depression screening, and then for those who screen positive are able to do a warm handoff. So within 30 minutes, have a behavioral health provider there to begin behavioral health treatment. And whereas previously those patients were being screened based on the capability of the primary care provider or other team members, but this system enabled them to have screening and handoff and begin treatment right all within the same system. That's just one example. So I'm being told to do we have one more question or we're done?
Last one.
Last one, okay.
The New York DSRIP is sort of notable for the community needs assessment that they did kind of before their DSRIP, their recently approved DSRIP. Can you describe any similar kind of community needs assessment or sort of effort to get the input of the communities that are being helped by the healthcare systems in the DSRIP?
So for the current DSRIP, you mean? For the DSRIP
and also just any thoughts you have about for the next DSRIP as far as those processes go.
Mm-hmm. So for the current DSRIP, I don't have any specific details, but certainly can get those to you. Definitely the projects that the systems embarked on were based on what the local needs were at the time. I can find out more about how those how they determine those. And as far as future DSRIP, I'm going to defer that to the panel discussion about the future DSRIP, if that's okay. Thank you very much.
Good morning. My name is Peter Harbage, and I am just going to hopefully call up my slides. I used to be competent to staff myself and should no longer be trusted. There we go. And so in this part of the agenda, what we would like to do is start to talk about other states and the experience in other states and what California might be able to learn or not learn or take away from the experiences elsewhere. I'll go through some slides for 10-15 minutes, and then we'll have a panel, and as Ingrid said, we'll have, as Chris said, we'll have an extended period of time for questions for that, and we're looking forward to all of you participating in the conversation, and looking forward to having a great day. Thank you. Let me add my thank you for all of you being here. In terms of what we're going to cover, again, in the next 10 minutes or so, just briefly, what is DSRIP? I thought the presentation we just had was pretty good, so we'll do that quickly. We'll talk about different models for DSRIP that seem to exist in the country, key issues for model design, go over some of the facts in other states to help tee up the panel so we're not spending a lot of time on a background conversation, and then we'll have a quick conclusion. So again, DSRIP is, as was just explained, Section 1115 Medicaid waiver that's really about supporting transformation in a way that we haven't seen before in Medicaid. CAPH in California and Toby were key in exploring this and developing this almost 5 years ago now, and it's really exciting to be able to move forward with a project that is patient-centered, transparent, collaborative, accountable, and value-driven. And these are really principles that, again, California has set that we see in all the DSRIP programs that are being developed around the country. As we'll talk about, there are roughly 7. There's no formal definition of DSRIP that exists with CMS, as is often the case with their waivers. But we think of there as being roughly 7 programs. This presentation is going to really focus on 3 states, and we'll talk a little bit about some of the other ones. But these are really some of the key principles that you see as hallmarks of the program. And of course, DSRIP is new work for better outcomes. It's, the point was made that this is no longer a subsidy program. The era of Medicaid subsidies is over. It's long over. It was, you know, this notion of paying for volume was probably one that has never served Medicaid particularly well and has probably led and reinforced bad outcomes for quite some time. And so it's exciting to see DSRIP change that. There are really 2 models as we look around the country for how DSRIP seems to be working in other states. One is really hospital transformation, and California is the best example of this. It's really looking at transformation within the hospital, within the inpatient service, within the outpatient setting of the hospital, but mostly focused on the 4 walls of the hospital. And you see this again in California. Massachusetts actually just had their program renewed. They're a good example of this. We've spent a fair amount of time talking to the folks in Kansas, and they're another example of this, where, you know, CMS seems to be saying that hospital transformation is important. It's something that they want to see. I think they wouldn't have just approved these other states if it wasn't something that they considered to be a viable approach. and an important approach for them. We have some project examples here. Some of these are from California, some of these are from other states, but you get the sense of what it is that CMS is trying to achieve in terms of DSRIP. So again, the first one's California specific for sure. I don't think it exists elsewhere, but improving infection control within the hospital is something, again, that you would think of as hospital transformation. Improving the medical home model within the hospital so that you're better managing care when people come in is something that would fall into this category as well as diabetes work being done through the outpatient setting, and that's really something that's actually being done more in the Massachusetts setting right now, though certainly California has a number of chronic disease management programs. And so we really think of hospital transformation as one model. The other obvious one is regional transformation, and this is really what you see in Texas, and this is really what you see in New York. It's much more population health focused. It's much more focused on bringing different classes of providers together for the first time, trying to get clinics and hospitals, nursing homes, individual docs, all sorts of different provider groups and classifications together to really talk about creating an integrated care delivery system. And it's regional in nature in that what CMS is trying to accomplish is fundamentally different in New York than what it's trying to do in California in 2010. And that, for example, one of the New York goals is to reduce unnecessary ER utilization by 25%, reduce unnecessary inpatient utilization by 25% over a 5-year period. And so the hospital itself can't do that. There's no way for a hospital to do that by itself. You have to have partners, you have to have people in the community, you have to have social services involved. And so that's something that's really fundamentally different between these two models, and it's something California is going to need to think about in terms of what it wants to do over the next year and making a proposal. I think there's good reasons behind both models. I think both are valid. I'm not sure exactly which CMS is more interested in right now. It certainly looks like smaller states have been getting hospital transformation waivers, whereas larger states, again, like Texas and New York, have been doing regional. But that doesn't necessarily have to be controlling for what California wants to do. Again, project examples here include creating integrated delivery systems. You have this final bullet here. There's a major push in New York around HIV care. And again, that's something that takes an entire village to do. That's something that the hospital can't do on its own. This is just sort of a quick chart looking at a couple of factors that are differences between the two models. So again, both models require collaboration. Hospital transformation obviously is focused internal to the hospital. Regional, as we've been talking about, requires a range of providers to be involved. And to involve the providers like that, you need incentives for them to be involved. And so what you have in, for example, hospital transformation is that those dollars, the DSRIP dollars, are going to the hospital. In regional transformation, you have dollars that are being made available to the state that are allocated, again, across all of these different provider classifications so that everyone who's participating in DSRIP is sharing in the outcome, is sharing in the positive achievement of the milestones. So it's not just the hospital who's receiving state dollars for successful regional transformation. It's all of the providers who are successfully involved. That obviously makes it more politically and financially complex for those states, and we are certainly seeing that as my group helps stand up a couple of different hospitals in New York for this for the first time. And you also have Again, this notion where these incentive dollars have to be shared. And that's something that still hasn't been figured out in New York. We'll hear a little bit about how that's worked out in Texas and some of the complexity that went into that, since Texas is is several years ahead of New York at this point. Regardless of whether or not you pick a hospital transformation model or a regional model, there are several design issues, and just going to go through these quickly in the next couple of slides. But overall, it's deciding what providers are going to participate, setting a vision, project planning, role of managed care, and then sources of non-federal share. You need a way to pay for all this. In terms of deciding the participating providers, there are lots of options. Again, some of these are much more simplistic under a hospital approach, under a hospital transformation model. If you decide to go regional, you have many, many more decisions to make in terms of trying to figure out should, for example, in California's case, should you move beyond public hospitals to other public hospitals? And of course, the state has recommended that in their concept paper. Should private hospitals be involved? What do you do with non-hospital providers? So again, physicians in the community. Once you start talking about physician and providers in the community, do you just want to focus on safety net providers, or is it all providers? Do you want to try to bring in the widest group possible or not? Social service participation is something that can be pretty critical in terms of managing inpatient utilization and ED utilization that might be inappropriate, that's often overlooked. And so New York has a focus on social services that other states really don't, and that may or may not be something that people want to import here. And then the last two categories, behavioral and health and long-term care, these are certainly provider classifications that could be somehow included in DSRIP if people thought they wanted to be and should be. They are discrete categories, maybe a little bit easier to manage than saying, you know, we want to include all physicians. Maybe you want to just say you want to have behavioral health projects. And so that would be something that would be a little bit easier to manage, a little bit more circumscribed, and certainly something that could have a positive outcome on the system as a whole. Certainly as people think about how to maintain compliance with regimens and with chronic disease management programs, behavioral health issues are critical to that. As part of deciding what providers should be involved, you really do need to have a vision for what DSRIP's going to do. And I think California had a wonderful, powerful, simple vision, which is exactly what you want to have for the 2010 waiver. And I think for 2015, it's still, I think we as a community haven't really decided what we think the vision for DSRIP is. I think we have a general notion that we want to keep it going. I think we have a general notion that this work has been successful, and it has. We have a notion that it's important to continue to transform the system. But what exactly that vision is that we can articulate as a community for CMS to get them excited, because they have to get excited, and to get them involved, I think is something that hopefully the DSRIP work groups that DHCS is running can work on, and hopefully is something we're going to be able to talk about a little bit more today. Project planning, certainly part of what CMS is looking for as part of their DSRIP proposal are stretch goals that are transformative. This is something that we've seen in other states, is that they continue to push harder. They continue to push deeper evaluation. They continue to push deeper volume of metrics. You know, something, again, as was explained earlier, California was the first one, was the first state. And so, you know, CMS's opinions change over time. These are waivers. CMS can do that. And so as CMS continues to think about what they want their requirements to be, It's important for California to be responsive to that and to try to meet those requirements, because CMS has certainly no obligation to approve the waiver if it's not something that they don't want to do. So I think considering the rigorousness of the evaluation measures is pretty important. Part of this is, of course, is also understanding the role of managed care. In many of these other states, as well here, part of what DSRIP is doing is getting those states ready for managed care. California doesn't need to get ready for managed care. We have our problems with managed care, but we're certainly ready for it. So thinking about how managed care fits into this conversation, I think, is something that's pretty important, because if someone, for example, if a decision was made to continue to focus on hospital transformation as a model in California, then how can managed care step in and help with regional transformation? Is there some kind of companion program there? How do those pieces fit together? DHCS, of course, for the last 4 years has been engaged in the Coordinated Care Initiative, using managed care to try to build better care coordination between social services and behavioral health and long-term care services and medical services. That could certainly be done here. There's no reason to think that DSRIP is the only way to achieve regional transformation, but that's something that needs to be thought about and considered. Finally, the major design issue we flag here is sources of non-federal share. For a lot of people, this is where the conversation will start and stop about what can be accomplished. If there's no funding, there's no funding. There's no way to do it. Certainly, Medicaid obviously is a matching program, so if there's no general fund contribution coming in, that means you need to find dollars to put up for DSRIP from some other means. There are different options for that, and we'll talk about what other states have done in terms of their options with designated public programs, or what are called sometimes DSHP programs. We'll talk about how Texas leveraged their mental health funding as part of all of this. But if we're going to expand beyond the public hospitals as a state, and again, no decisions have been made, there's just a need to understand what those funding sources are. And I think right now there's not a shared understanding of what those options are or what could be done. And so I think that's something that'll be interesting to hear from other panelists today. So I'm just going through these quickly. This is a quick chart on some of the other states that have DSRIP programs. So you have across the top California, Massachusetts, Texas, Kansas, New Mexico, New Jersey, New York. You have across the bottom the dates of those approvals, so they're in chronological order. As you can see, California is unique in that it's the only state that is focused solely on public providers. You also get a sense in that top box of what states are focused on hospitals versus including other providers, versus including other providers and social services. And so it's really Texas, New Jersey, and New York where you have this focus on regional transformation. And again, some of these otherwise smaller states, Kansas, New Mexico, Massachusetts, not that small, but still only has 7 hospitals in the program. In terms of who is hospital only. I think in the interest of time, I will just let the rest of this slide go for now so we can keep things going. Ingrid is telling me we need to keep things going. She's good at that. So just a quick summary of the 3 states we're going to be hearing from. And again, this is just to tee things up, as I am not the expert on all of these. We're going to be hearing from Massachusetts and their DSTI program. This was just renewed for 3 years after an initial 3-year launch. My understanding is Massachusetts had decided that given the 3-year window, it really wasn't possible to have a population health transformation program. It's just not long enough, just not enough to really achieve the kind of change that you're looking for. So it is a hospital-focused program There are 7 hospitals involved. Each will have 6 or 7 programs, and we're going to be getting an update on where those projects are and where they stand in terms of implementation. Again, I think the waiver was recently approved in October, and so we'll be getting an update on that. And again, the goal is to prepare, part of the goal, as you see in the last bullet, is to prepare for complete elimination of fee-for-service Medicaid in Massachusetts. So again, you have this focus on capitation, you have this focus in other states on managed care. New York is underway, and their applications, their DSRIP applications are due on December 22nd for all of their hospitals. The projects there are regional. There are going to be about 25 regional entities that will be focusing on population health with statewide measures. Obviously hospitals will be transformed as part of this, but that's not the focus. There are tens of thousands of providers who are going to be involved in this effort in New York. It is a massive reorganization and rethinking of how they deliver safety net care. That's pretty exciting, and we'll have to see how it goes. Still very, very early in the process. And certainly, again, a big focus there for them is preparing for capitation. There's not a lot of use of capitation in New York, and so all of the different regional organizations there, as part of participating in DSRIP, have to agree that they're willing to accept capitation in 5 years from the state. Texas is one of the more mature programs that's going on right now, and so it'll be great to hear a little bit more about where they're at and what their experience has been. I think they are also thinking about getting ready for their renewal process, and so that's something that'll be good to hear about where they're at. This is really a much different program than California in that they just have a massive number of projects. CMS inflicted a fairly high level of rigor on them in terms of data analysis and evaluation that was needed for each of their programs. As you read in the companion paper to the slides that we gave out for the event, one of the hospital regions simply wanted to add 2 gastroenterologists for 1,800 visits a year for specialty care, and this required something like 12 pages of evaluation metrics over 5 years with numerators and denominators and all sorts of different data collection, which feels like overkill to monitor 1,800 visits. But that's what CMS chose to do there. Fortunately, that does not seem to be what they're doing in New York, and I would not expect it to be that bad for California. But it does give you a sense of the flavor and the difference in what is being done in terms of evaluation. But again, Texas, like New York, strong population focus, public-private providers involved, and we'll hear get to hear about some of the politics around that. In conclusion, just want to remind folks, of course, waivers are completely at the discretion of CMS. It's important for CMS to want to do this. They have to be excited about it. They have to see the value in it to them. They have to see the value in it to the system. Waivers can sometimes be misperceived as free money, and they're just not. And so it'll be interesting to see how the waiver as a whole and DSRIP in particular develops over the next several months to try to draw CMS more into this process, build alignment with the federal government and the state and all of us here in this room to try to achieve the change that we want, and hopefully get the best possible deal for California. So I think what I want to do is not take questions on the slides because I want to get the experts up here. And so if I can go ahead and call up the panel, maybe we can go ahead and get started. It looks like everyone's here, so that's good news. I guess we'll leave that up at least for a minute.
Yeah.
I'm the biggest stand the whole time, so I can yeah, so I'll just sit there. Okay. Yeah, I'll hang on. Okay, so why don't we go ahead and do introductions first, and I'll let all of you introduce yourselves and start with Dr. Shaw and maybe just work down the row, and then I think maybe folks have some introductory remarks, and then we'll ask some questions and get the audience involved.
Good morning. My name is Nirav Shah. I am a general internist and now Senior Vice President and Chief Operating Officer for Clinical Operations at Kaiser Permanente in Southern California. Until May, I was the Health Commissioner of the State of New York, and in April, we received our $8 billion Medicaid waiver. There's bios in our...
Congratulations. I'm Tom Traylor from Boston Medical Center. I'm a vice president. Additionally, I serve on the board of America's Essential Hospitals. I have been at the hospital and with the essential hospitals for 30 years, so I have followed this process and waivers certainly for a long time, including the 20 years and the 6 waivers Massachusetts has had. So when I look at this I look at it at a high level as a continuum. So very interested in coming, and did want to thank at the onset CAPH for their pioneering work, and Toby and the folks from the state to do this, because as Chris mentioned, Massachusetts did draft off California's first DSRIP for our DST. We can get into that in a little bit.
Good morning. My name is Billy Milwee. I'm currently a managing principal with Sellers Dorsey. Before that, I served in Texas as a deputy Health and Human Services Commissioner and state Medicaid director, and did that for a number of years. I left Texas Texas Medicaid in August 2012, just after we negotiated the waiver to pursue some other opportunities. We obtained our waiver shortly after California, I think. We got final approval in December of 2011. December 14th, 2011. In fact, 2011, I was in California at the time it was approved. But anyway, thank you, California, for blazing the pathway.
Great. So I think the panelists all have maybe a couple minutes of introduction that they want to start with, and why don't we do that? And we'll start asking questions. Just want to go right to the questions. All right.
Fair enough.
We're saying go right to the questions. So we'll go right to the questions. All right. So one of the design issues I led with was to talk about the importance of having a vision for what needs to be achieved. And I think, again, California is really still at the beginning of its DSRIP 2.0 process, and so it would be great to hear a little bit more about the vision that each of your states had, and understand maybe a little bit about how that was developed and how that came about for you and why that was important. And maybe we can use that as part of the California learning experience. But maybe start with New York and just keep going down the line.
So first of all, thank you, California, for paving the way with these waivers. I think this has been one of the more important things that CMS has done thoughtfully over the last few years to really help get us in healthcare to where we need to be in a short order. You know, there's several questions you can frame up when you're talking about a waiver, and we started by thinking, you know, how do we improve healthcare delivery? And we decided that wasn't the question we wanted to answer. We wanted to answer the question, how do you improve health? And when you start with how do you improve health, not health care delivery, you come with very different answers. We had just gone through a exercise like Let's Get Healthy California, of creating our own 5-year prevention agenda for the state of New York. We'd done deep dives into the data, not only in Medicaid, but across the system. And while HEDIS and Joint Commission and NCQA have done a lot to improve quality in our hospitals over the last few years, much less attention had been paid to the social determinants of health, to moving upstream, to moving outside the four walls of the hospital or the healthcare delivery system, to really start to move the bar. So when Mrs. Jones shows up and gets readmitted 7 times to Maimonides Hospital, what's causing that? Well, it may be because of unstable housing or abuse at home rather than congestive heart failure. And when you start to look at other drivers of high-cost, high-need patients, things like gaps in treatment of behavioral health, that we found that there were lots of providers outside of the traditional healthcare delivery system who were fundamental to the answers we were seeking. How do you optimize health? How do you improve health? I heard a statistic today that 40% of the uninsured are seen in California's public hospitals. Well, that means 60% are seen outside of the public hospitals. And so for New York, it became clear early on that the vision was beyond what was up there. There was a slide that says patient-centered, transformative, accountable, collaborative, value-driven. And we replaced the word collaborative with interdependent. Hospitals are equal partners with the providers in the community who know the patients, who know their patients, before they become patients, and who can help them stay outside the hospital. So that realization allowed us to take that deep dive and force an in-depth community health assessment, and ultimately led to the waiver as it is. I'll stop there.
Okay. In Massachusetts, I think the most recent version of the waiver that included DSHD, I would say, was aligning the ACA with our cost containment legislation recently passed in Massachusetts. We call Chapter 224. In Massachusetts, we have near universal coverage and have had it since 2008 or 9 or so. And so looking at now that we have probably as many folks covered as we can, how do we bring the cost of that program down? So the legislation that was passed looked at containing cost and limiting medical inflation to no greater than normal inflation. And it's been successful over 2 years. So it was in that context that the state applied for the whole waiver as to how would DSHD fit in. Again, drafting off California in the DSRIP program, how would we take that piece and put it into this overall reaching goal now that we actually have covered? How could we address bringing it down? So I would say when we think about DST, as we call it in Massachusetts, I guess the T, we're transforming instead of reforming. I don't know if that's more aggressive or not, but the program was set out to be sort of a piece of the puzzle, and not the puzzle itself. So maybe if you look at sort of how do you address what's the size or the shape of that puzzle piece, in my mind, it's how does it fit in with what you want to do in the bigger? What does the puzzle look like? Of course, it's different in the different states. We have the universal coverage or near universal coverage, so our goals are different. So we looked at what it would take to move cost containment, and the direction there was to move towards not so much to managed care or capitation, but to what we call alternative care, basically taking the risk down to the provider level, the risk or rewards, ACOs, if you will, or something along those lines. And so the direction of the state was to go that way entirely and move the Medicaid program out of fee-for-service. So as the state designed DSHD, it was how does that fit with all of the other parts that are moving the state forward and not sort of an end unto itself. And so the state's decision was these 7 hospitals were the most disadvantaged, and so we needed to bring them up to a lowest common denominator to be ready for this brave new world of provider risk and being rewarded for less care, if appropriate, with high quality and so forth. So it was really just a piece. There are other parts of our waiver that pertain to other parts of the system, but that is why they looked at these 7 hospitals and continuing that. Peter mentioned in his slide there that we ended up with 3 years of DSHD. That wasn't because we couldn't do population management in 5 years. Mm-hmm. It was because CMS wanted us to go there and we didn't want to go there. And so although CMS changed that worldview 9 months into the negotiation, there wasn't enough time to do it, so we ended up with DSRIP 1.5, if you will, and not the DSRIP 2.0. And so we have 3 years of continuing our current DSRIP program. So there was a disagreement in sort of what works in our state and why these 7 and what the vision of the state was. So we continue to be in that negotiation. In fact, the rules around DSRIP and the metrics are under negotiation now. It's supposed to be done by the end of January, but that certainly won't happen. So I suspect it'll be into the spring. So more on that in a while.
So just to follow up on that real quick, so CMS partway through the negotiation decided that they did want to do population health? Or?
Well, they wanted a different approach. They changed. So for 9 months of the negotiation, our DSRIP could continue. Our DSRIP originally was only 3 years, and it got approved 2 weeks before the end of the first year. So we had 1 year of DSRIP, and then, of course, you have to start applying 12 months before the next waiver. So 12 months in, we were negotiating the next. And so we asked for a continuation, saying 2 years in a 3-year time frame isn't enough, and asked for 5 new years. And that was going forward, and they were impressed with the results, and everything was positive. We were going to have a 5-year renewal, basically, of our 3-year program. 3 months to go. They changed, and I guess got enamored of New York and a different worldview. And then they agreed there wasn't enough time to do that in 3 months. Our waiver was up, July 1st. It was approved end of October, but not completely approved. And so we agreed to continue this negotiation, which to us feels now like a perpetual negotiation, because of course, yes, once we agree to the year 1 here, it probably won't get done until, this is a July through June. The first year will be done in a 3-year, and we have 12 months to start the next cycle. So. And we're at a different point in discussion with CMS about what would work and wouldn't work. I mean, the hospitals are in agreement with the state, but see, that approach doesn't work well in Massachusetts, perhaps because we're at a different place in access than maybe New York or Texas, I'm not sure, but wouldn't necessarily work. And we also worry about the sustainability of that model.
Great, thank you.
So going back to 2011, that was when before the Supreme Court had ruled on the ACA and Medicaid expansion was a foregone conclusion. And Texas was looking at Medicaid expansion then, because there wasn't an option, and looking at 1 million members potentially coming into Medicaid. Texas, as you know, has one of the highest uninsured rate in the United States, a tremendous burden in uncompensated care, about $5 billion a year in uncompensated care. So with that, we had an environment where we weren't ready to take on that many new people coming into Medicaid. The hospitals had not been able to invest in infrastructure, and there had been no additional funds available. So we weren't prepared for 2014. So in California, I believe the waiver here was the bridge to 2014. We built the runway to 2014. The plane never landed. But anyway, it was a runway to 2014, and we were going to use those dollars, and we have used those dollars to invest in infrastructure and those kinds of things that you need to build out a system to accommodate more people and to improve the quality of the services that you offer. Texas had been in 2009 and 2011 building our Medicaid program structured largely around population health measures, around preventable ED admissions, preventable hospitalizations, and preventable readmissions. And so we also saw that as a vehicle to take that further into the commercial payers and other payers as well. And so that was the reason for the waiver. We structured it on a regional basis because, one, Texas is large. There are very, very different needs throughout the state. We had eventually developed 20 regional health partnerships, and the belief was then that over time these regional health partnerships would then form the core for collaborative care organizations, and that's yet to be seen, but it may happen in time. Another vision really drove the waiver. In Texas, we had a huge dependence on upper payment limit. In Texas, prior to the waiver, we had about $2.8 billion in the system through upper payment limit. When you expand managed care, when you have capitated managed care, CMS says that UPL is incompatible with capitated managed care. Those days cannot count towards your UPL payment. So we had to preserve that UPL position, we had actually carved inpatient services out of our integrated care model. So we have an integrated care model in Texas known as STAR Plus that offers acute and long-term care services, but had taken the most expensive component out to preserve UPL. So another part of the waiver was to redirect UPL so we could continue the flow of dollars, but not have it and continue to expand managed care. So it would become more rational more appropriately applied to investment versus just a UPL kind of financing mechanism.
Great. Maybe as a follow-on to those conversations with CMS and how the vision was developed, it makes sense just to talk about what that interaction with CMS was like, and I think we got a sense of that already from Tom. But Nirav, in terms of New York, you know, how was that interaction? Was it contentious? Was it difficult? Did you find it collaborative? And again, always with an eye towards what learning do you think is relevant for California as we enter this year?
No, I think at one point we had about 350 spas in front of CMS while talking about the waiver, state plan amendments. So I think that CMS was absolutely always trying to do the right thing. There were bandwidth issues, there was coordination issues, sometimes internally, and we were part of the problem as well. But the reality is it took 18 months, and it took several about faces to get us to our waiver that was ultimately approved. You know, one time we're like, okay, so what do you want us to do? We gave you this waiver. Well, give us New Jersey's waiver. So we copied New Jersey's waiver, pasted it, you know, replaced all the words appropriately, sent it in a few months later. No, we actually want something else. And so I think that their thinking has evolved over time and will continue to evolve over time relative to what they're learning from CMMI, relative to what they're learning from all the other initiatives. And so it's kind of a race to try to get something in before they change their mind again. No, but it was a very collaborative process. At the end, what we ended up with was truly incredible. It's not waiver 1.0, it's not waiver 2.0, this is waiver 3.0. And it's pushing us in ways that it makes us quite uncomfortable.
Fair enough. Did you want to add anything to what you said before?
Just well, from my view, of course, as a hospital, we were a third party or once removed from the negotiations. So certainly in everyday communication with the state around them and doing briefing points and rebuttals to things CMS was saying, but it's harder to do it. We weren't at the table in this round. We have been in some of the prior rounds, and our clinical folks have been in the table around some of the projects, but not so much in the framework and the negotiation. I'd offer a little bit different worldview than Peter's view about it. Certainly CMS doesn't have to approve these waivers, but from my view, it sort of, we should move away from just a standardized waiver that is centrally imposed by CMS and looking at the states as the laboratory of changes. They certainly don't have to approve them and they have to be budget neutral and so forth, but I think, to be told, we want you to be like New York or New Jersey, because we don't like that. I mean, might as well be rooting for the Yankees, right?
It's not a bad
thing. But seriously, we're just saying it doesn't fit for Massachusetts where we are. We're very different than the other states. We're small, we have full coverage, and so what we're trying to do to have those measures sort of imposed, and I get the bandwidth issues at CMS on the hundreds of measures that they have to do and try to standardize some things. But we're hopeful they can understand with a better message around sort of what we're trying to do and to better understand what Massachusetts is about, these 7 hospitals, and how it fits into the bigger picture.
Well, I can't say enough good about our relationship with CMS at the time. Cindy Mann was extremely accommodating with the waiver, always had a thought about how we could get something done versus telling us no. So we had some very, very good conversations around that. There were some sticking points. The DSRIP menu, we had a similar occurrence where the suggestion was that we use the California DSRIP menu, and we said, well, okay. And then they said, well, but you better just go ahead and develop one for Texas. So we had to do that. And so it's a little missteps there. I guess the biggest issue was private and public hospital participation. CMS did not want to see a system built around public hospitals that would just solely have Medicaid members just going to public hospitals, particularly when you have in Texas a system structured so that you have many, many, many private safety net hospitals as well. That wasn't a tough point to cross because in Texas, a lot of our hospital financing is generated by public hospitals and hospital districts that provide IGTs that support the entire system. So in Texas, public hospitals, healthcare districts provide an IGT that then funds DSH and upper payment limit, and private hospitals share in that benefit. They didn't want to also see, we were very concerned about disrupting the entire hospital financing system. Private hospitals, by participating in the waiver, continue to provide that relief of burden, if you will, for the public hospitals that would not have to take on that entire population absent the private hospitals. At the end of the day, CMS was really, they started out as mandating that all private hospitals that participate in the waiver participate in DSRIP. That would not work. All the private hospitals could participate in uncompensated care, but we finally negotiated it down to about 30% per region would participate in DSRIP, and that would be the maximum level that CMS would look for.
Let's stay on that for a minute, because I wanted to actually pivot to what it was like working with some of the stakeholders, and again, and understanding how things fit together with CMS. But in each of your states, both public and private hospitals are involved, and there can sometimes be tension there. And so, Billy, what was like that? What was that process like for you in terms of being the Medicaid director, trying to bring those different classes together and have that conversation with folks?
Well, it certainly was challenging at first because there was so much money at stake. And anytime you're going to disrupt the status quo, you've really got to gain a lot of trust. And we had, like I said, $2.8 billion in UPL through a financing mechanism that had been in place for a decade or longer. So you had to create that trust. I think what helped, though, is that we were able to enlarge the pie, and we didn't look at it as a limited pie. I mentioned the $2.8 billion over 5 years. That's about $15 billion. Through the waiver, we were able to bring in $29.8 billion, almost $30 billion. So there's more opportunity for everyone, and I think the state in that role had to be the regulator that would I think we built an amount of trust between the public hospitals and private hospitals, but we were able to put some things in rule that would then manage behavior. It wasn't a easy process. It took some time, but eventually we got there.
And Tom, I think Massachusetts is probably in a slightly different place, since you weren't building these regional partnerships where you had to have public and private hospitals working together. But what was some of that process like from your perspective?
Well, as far as DSRIP or DSRIP goes, it was really the 7 hospitals that were involved, mostly exclusively with the state. There were certainly other stakeholders and folks interested in the state, but not so much on that program. That program didn't include new dollars, so it was seen as a changeover of supplemental dollars to a new form that aren't just directly dish payments, and you had to have metrics to achieve them. So everybody thought that was a good direction and okay in sort of, again, old dollars. Other parts of the waiver, folks were interested in, the stakeholders were more active in other pieces, including the subsidy level difference in Massachusetts healthcare reform compared to the ACA, and getting a wrap payment in the waiver. There was a CMMI grant that we have, and that funds other parts of the system. So again, for DSHD, not so much interest beyond the 7, but the rest of the puzzle, everybody was interested in the waiver, as well as pieces outside that.
You know, you probably had more of a Texas experience trying to bring public and private hospitals together. What was that like?
Well, actually, you know, there was an actual crisis in New York 4 years ago where we had a burning platform where everyone was worried that, you know, private hospitals were closing. Public hospitals were struggling much more than they are today. And so that crisis brought us together and really focused us in ways that allowed us to have those conversations starting 4 years ago, which was really the birth of our waiver. And those conversations evolved over time into that prevention agenda, into a successful CMMI grant, into all of the things that led to this waiver. Because we knew the other partners, we knew each other, and we'd had these difficult conversations in public, actually.
Do you want to talk a little bit about the MRT and tell folks what that was when you say there was a crisis 4 years ago, and maybe use that as sort of context for how you got to the waiver?
So 4 years ago, we were at a place where New York's Medicaid program was $54 billion, growing 13% or more every year, crowding out education, crowding out everything else. It was among twice the national average in terms of per recipient spend, and last in terms of readmissions and quality on many different metrics. We realized that this was unsustainable and unfair to our taxpayers, and over a very short period of time, literally months, the governor convened folks together and said, figure it out, or else everyone's getting a haircut indiscriminately. And that really focused people. We were able to go around the state and collect 4,000 ideas on how to fix Medicaid. And in short order, I mean, these are not rocket science ideas. Moving to managed care will save money. Increasing your generic substitution rate can save $425 million a year for Medicaid in New York. But collectively, the fact that we went through that exercise together and openly had these difficult conversations, and individual advocates who had their one position, who traditionally won in the legislature, got drowned out by the evidence, or other advocates who had the evidence behind them got elevated, created a sense of trust where we are doing things that will improve population health, improve quality, and decrease costs. And the proof was 13% down to 4% growth, 3.8%, and going smaller. That cumulatively adds up to $34 billion in savings over 5 years. And so that conversation, that process, that open process, which was painful, it was traveling around the state. I mean, I got pink eye from shaking so many hands. It was really painful. It worked, and it allowed us to have those hard conversations and no one voice to shout out the others. And it set the stage for that success.
Great. I think we have some more time for questions here, and then we'll go to the audience. One of the things I wanted to touch on is another design point mentioned in the slides, and that's project selection. And I'd like to understand a little bit more about how your states decided what projects you wanted to work on, understanding that you were alternatingly told to copy from California or New Jersey and then not, and then understand your perspective and the CMS perspective on it. And Tom, maybe we'll start with you on that one, since you're in the middle of picking your new round of projects, I guess.
Yes. So first we started off drafting from the laundry list from California. The projects, though, during negotiations several times we pointed out, well, to approve that in California, it was like, we'll pick the hard ones from California. So again, coming second, we went through that, but it was definitely, our 4 categories, I think Peter had it in his paper, were slightly different, with more of a focus on moving towards alternative care. Because the coverage was completed. The project lists were similar by categories, moving towards integrated care, chronic diseases, and so forth. So they started from the hospitals, rolled up, approved by the state. So we had 2-level negotiations with the medical director of the state. And then later in a 3-part with CMS's clinical folks. So it was the waiver team, additionally folks from SAMHSA and CMMI and others around negotiating the project, and a little back and forth about pushing the degree of difficulty up around the metrics. So we got to the list. One thing we did learn from California, we went down to around 7 or so projects per hospital as opposed to 15 to 20, which seemed like too many to focus on. So we were glad on that. And on our percentages, most of the hospitals have achieved most of the dollars. We ended the 3rd year, some 100% for the 3 years, others in the high 90s. So a high level of accomplishment. Of course, CMS said that the targets were too easy then, if we were able to achieve them all. We reminded them there was a 3-way negotiation. Everybody signed off at the time. So, but anyway, so we worked. That's how it worked externally. Internally, it was set up a little different. I mean, each of these projects, of course, have a dozen or 10 folks with them, clinical folks, to design the projects. And we have designed, and for this DSRIP 2.0, a 5-year version, which now we have to condense to a 3-year version, which is what we're in the middle of now, and sort of, and that is not complete. But a lot of work internally with the clinical individuals around designing these projects and how far you move. We certainly follow the other states, what are the metrics, the details about the individual projects that are of similar nature. So we go through a criteria. We had them actually listed when we did this internally, that the issues had to be topical, of interest to CMS, had to be measurable, had to be things that had the quality goals that we're able to quantify in the end. We would want to champion things that the hospital was interested in moving in that direction anyway. They were the right things to do, and we were doing them independent of DSRIP. We needed to have a strong team or a champion within the hospital to be able to accomplish these. We had terms, they needed to be rescuable. If they got in trouble, that we could put some resources on them to bring it out if it hit sort of unforeseen troubles along the way. Because after all, these dollars were critical to the hospitals, not just Boston Medical Center, the other 7 significant amounts of dollars. And without these dollars, we couldn't get where we are, which at the end of the day is about a break-even situation. So they're critical dollars to us. So failure wasn't an option here for us, give or take a few percent, and we had to accomplish these. So they were driven, from the hospitals with the state sign-off and then from CMS.
And when do you think you'll have a final list for your new round?
Well, the terms and conditions, I think it was 400-odd pages also in this latest version that was finalized October 30th. The term and condition on these measures said there was a target date set of 90 days, which would take us to the end of January. We have a new governor starting the 9th. In 3 weeks, and so it will certainly not get done, I think, in January. My guess would be into the spring.
Okay.
So we've got several more months to go. We haven't really went through in earnest that process like we did the last time, where each of the clinical teams could get together, and really that's where it gets met. The folks that understand the state-of-the-art measures in each of the projects and the diseases, what is a doable stretch goal enough but not impossible to meet, so that, that will take some time.
Okay. Billy, Texas just has a massive project list. Why don't you talk a little bit about that development process and your thoughts on that?
Well, we started with the simple and very quickly moved to the complex. The simple part was looking at what things really matter in healthcare and what drives costs and also impacts quality in a negative way. And we looked at things like inappropriate hospital admissions or primary care preventable hospital admissions, complications that occurred during the hospital visit, readmissions post-discharge that potentially could have been prevented, use of ancillary diagnostic services like MR, CT, and those kinds of things, and then ED visits. And said, well, if we could frame the waiver around those 5 things, we could get we could rebalance primary care with that being one focus, and we could look at overall spending. I think the National Institutes of Health assign about a third of your cost in the healthcare world is associated with those 5 things that really you could eliminate it and not have a negative impact on the entire system. Then we went to the California DSRIP waiver and that menu. Then we had to convene a group of champions for our DSRIP menu, and that resulted in a rather large menu and a number of projects to choose from. We went down the path of thinking, well, should we mandate certain projects that every region, every one of the 20 regions must participate in, because there are some things that are in the state's interest. Maternal and child health is a major issue in Texas. But finally, we decided to go local. Really let this be a bottom-up versus top-down kind of style. We have the menu that has been approved. We have required each regional health partnership to develop a community needs assessment. So wouldn't it make more sense to let the projects flow from the community needs assessment that are within the DSRIP menu? And so that's ultimately what we did and how we wound up with 1,500 projects. And most of them, though, as you look at them, are really around primary care, integration, behavioral health, things that make sense. Looking in retrospect, I think I might have trimmed it back a little bit.
Rob, you blissfully have 44 projects in the New York list.
Well, I think we learned our lesson that it's very good to spell things out in detail and manage expectations and say, when we want you to do a community health needs assessment, we want you to do the following. Things like find out which libraries have hours of internet open to the public. That's the level of detail we expect from your community needs health assessment. Once you've got that, then you actually understand your community. Oh, and by the way, we're going to give you a lot of data as the state on your populations. We actually have a lot of it, and here's what we see. Here's how patients are moving from one institution to another. All of this in easy-to-use self-service dashboards. That's the vision. We'll get there. But that really helps. I mean, being very proscriptive about saying this is the data, these are the things that you need to go through before you come up with projects, and here are lists of projects. For example, and 4 domains of the projects, and all of this is available on the internet. Tools, transformation, clinical improvement, and population health. Building off of what you've done in California. Tools, how are you integrating your data systems with the regional health information organizations, the RIOs. Transformation, how are you doing care coordination and building off health homes and other existing initiatives across the state of New York to really coordinate care across the continuum. Clinical, Obviously, all the measures from HEDIS and others that we're now taking to the next level. And population, things like naming that maybe you should consider the nurse-family partnership for improving outcomes among low-income Medicaid moms. Very proscriptive in some of the projects, but then allowing them, with the support of the data, to really get to where they need. And we were imposed this because if we don't hit our metrics, if we don't hit a reduction of 25% in avoidable hospitalizations in 5 years, actually 5.5 years, we couldn't do it in 5, the money stops flowing. You know, by year 3, money stops flowing unless we actually meet these metrics. And they stop flowing for everyone, not just for the 1 or 2 projects that aren't meeting the goals. So it forces everyone to help everyone else out to succeed in ways too.
I think what I want to do is, before we transition to the audience, is talk for a little bit about non-federal match, and maybe just ask each of you to spend a couple of minutes on your sources of match. I think New York is fairly, I don't want to say complicated, but certainly interesting, and Texas. And so maybe we can start, Nirav, just stay with you for a minute, and you can talk a little bit about how some of those systems work, understanding that there's not a lot of time to talk about it.
Yeah, I'll keep it brief. It was a long, complicated decision which changed many times with CMS. We'd propose things, they'd come back with us. Cindy Mann flew down to talk to us once or twice about it. It was very complicated. At the end of the day, most of it is IGT, and some of it is DSRIP. But I think your circumstances are going to be very different here. Your opportunities are very different in California than New York.
And Tom, how is it working in Massachusetts?
Well, for the DSRIP program itself, most of it, about 80% of it, is actual general fund from the state.
And we should just say DSRIP real quick is where you take an existing state program and basically, you can tell me, I would say Medicaidize it, and say it's now matchable with Medicaid dollars, and those Medicaid dollars come in from the federal government, so you can fund other things. And so you're saying that it's mostly DSRIP for...
Oh, no, for DST. For the DSRIP, right. For the DSRIP program, that is 80% general fund match for the non-federal share.
Oh, you actually do that
and
out
about
east.
20% IGT. We only have one pure public hospital in Massachusetts amongst the 7, so there's a real general fund match for the... though it's not big dollars, it's only about $90 million per year in the bigger picture of about a $12 billion Medicaid budget. So we're doing that. We do have DSRIP within there, so again, the money's fungible, and there is additional DSRIP money coming into the state, though that tails off in this 5-year waiver. So I don't know if it was good. We actually had a 5-year renewal, of which only 3 years of DSHT and some of the other programs were agreed to for 3 years, and will be renegotiated during the 5, for year 4 and 5, and perhaps past that. So the DSHP dollars did get reduced and eliminated by year 4. So the state has some additional DSHP dollars in years 1, 2, 3, but not past that.
Okay. And Billy, I know you were nice enough to put together actually a small paper that we've distributed here today, and so I appreciate that on some of the dollar issues in Texas. But if you can summarize some of that, that'd be great.
Sure. So the vast amount of the money comes from IGT. In Texas, I mentioned that the previous UPL program was funded by hospital districts and public hospitals. So those dollars were then repurposed to fund the waiver. Additional dollars came from the local mental health authorities, community mental health centers that received a general revenue from the state or funding from a local government to provide an IGT, and also counties and cities. What we looked at when we got the waiver, we had more dollars in the waiver than had been represented in the previous UPL program. So we literally were looking for any unmatched dollar that was being spent in anywhere in healthcare services and potentially outside of healthcare services. When we had town hall meetings around the state, invariably the county executive, we call him a county judge in Texas, would come to me and say, I've got to do something about my jail care costs. Well, I can't do anything about that. I can't pay you for jail health care services, but we can talk about jail diversion programs through your community mental health authority. And so those kind of dollars would be shifted over to then become an IGT that really permeate the local health department, the cities. It builds up from a local level all the way to the government level. So primarily IGTs.
And some mental health dollars and?
Yeah, mental health dollars that had previously been unmatched. I mean, if you look at a state and look, where are you spending dollars in health care that are not matched? Those then become a potential source for IGT.
Okay. So with that, we're going to transition to audience questions. And I think I'm also going to take that as an opportunity to sit down at the table. And I think the first question Ingrid is trying to, here's Molly, is tee up, is going to be on behavioral health.
Great, thank you. Molly Brossel with representing the county behavioral health directors here in California, so our local mental health plans and also our local alcohol and drug programs. Really appreciate the panel, great expertise and experience from your states, and I particularly am interested in hearing more about Texas and your partnership with your county mental health plans. There's a couple comments and then a question. I was intrigued by Dr. Shaw. I think your opening comments, you mentioned a focus on health rather than just health care, and in behavioral health, I think that's particularly important as we think about access to behavioral health services here in California. We've made tremendous strides over the last few years. We've increased benefits, we've increased coverage for individuals who used to be uninsured, and we've increased managed care enrollment, as you're probably well aware. But what we haven't made tremendous strides in is improving the morbidity and mortality of individuals with serious mental illness who continue to die 25 years younger than the general population of primarily very treatable chronic conditions. So we're very intrigued by the opportunity a DSRIP may provide for improving outcomes for this population, the population with serious mental illness who do struggle with chronic conditions at a higher rate than the general population. So I guess my couple of questions are, to the extent that in your state DSRIPs you've partnered with or worked with non-hospital systems or providers, have those all been within the context of one large DSRIP program, where those were discrete projects with a focus perhaps on specific target populations, maybe a behavioral health population or others? Or is there ever been, maybe this is a question for Peter as well, more than one DSRIP in a state? And to what extent, perhaps, would CMS entertain having more than one DSRIP in the same state?
I think the answer is both. If I'm understanding your question correctly, it's could you have a isolated community mental health center doing a DSRIP project, or could they be doing something in tandem with other providers? I think that's it. And if so, then the answer is, what I've seen is, Peter mentioned that hospitals can't do these things on their own. No one person can function independently. What I was intrigued about is when we were doing these town hall meetings around the state, is many times I found the hospitals had not been talking to the mental health authority. And that probably didn't happen here, but it was happening in Texas. So when we looked at our preventable readmission data for the state, what was costing the Medicaid program a fair amount of money was substance abuse and mental health conditions. And we could not hold the hospital necessarily accountable for that, because when you look at what they were dealing with, the infrastructure they were dealing with in the mental health world, there wasn't a whole lot of support there. So what you saw are some community mental health centers collaborating with hospitals on reducing the readmission rate for substance abuse and mental health services. And then you see some co-location going on with primary care, with behavioral health providers working with primary care providers. On the seriously mentally ill, you see a lot of crisis intervention programs and programs that are designed to independently from any other provider group, hospital or public health department, any other, the mental health providers working on programs for the seriously mentally ill and jail diversion programs.
So I have a small question, which is, for the geographic areas for these regional projects, what's the acceptable range of the size of the geographic area?
I think it varies by state.
Yeah, it depends on the density. You know, Brooklyn is a geographic area. Upstate New York, almost all of it is, you know, a few geographic areas.
Well, I was thinking in population. So I'm from Los Angeles County. Could we have 20 geographic areas represented in health neighborhoods or something like that? Or would we have to, it's just trying to, as we plan, what's the acceptable scale? Does it have to be a whole county? Could it be parts of a county? What kind of approach is acceptable?
We didn't run into problems with CMS trying to dictate that. It was more, what's your rationale? So we have RHPs that are one county. Dallas is one county. Dallas County's its own regional health partnership. There are no other counties, and we have them as large as 20-some counties.
It really depends on the partnerships that you build and the hospital service area that you have. There's a focus on trying to build on the natural boundaries of what's already being offered, and so what they're doing in New York is looking at that and trying to evaluate that. So it can vary. Sorry.
Hi, this is Lisa Sugarman with Health Management Associates, and I wanted to build off of the question that Molly just asked about integration with behavioral health, and I'm really intrigued, and this may be a specific question for New York. I'm intrigued by the idea or the potential for integrating social services and even long-term services and supports, which could be a possibility here in California. And I'm curious, from your experience, how did that come about, and what does that really look like in the way that it has been planned?
So let me start by saying this was an extremely data-driven initiative. You know, we have really high-quality, individual-level data on our Medicaid dollars being spent in relatively real time based on claims, 3 months, a nice data warehouse. So we were able to say, this is the impact of not addressing this problem. And when we were very clear on what the impact was on not addressing behavioral health, for example, we could make decisions that no one could argue with. Things like putting state share only dollars, 300 million state share only dollars into supportive housing, where it's housing units with maybe some substance abuse or behavioral health counseling in the basement, right? Because we could tell you the 22,000 patients in Medicaid who were costing us $1 billion last year, who were either homeless or stuck in a nursing home and didn't need to be there, or otherwise could have benefited from supportive housing. So we had that level of data that no one could argue with, and then we made decisions that seemed counter. You're using state share only dollars. This is not matched to build supportive housing. Well, it's going to ultimately be the most important dollar we spend, for example.
Hello, this is Oscar Gomez. I'm a CEO with Health Outreach Partners. We work a lot with community clinics, community health centers here, specifically on their enabling services, everything that occurs outside of the 4 health center walls. And right now we're really working with them to try and identify some ROI metrics around some of these services. And so, I'm formulating my question as I say this. So I'm curious to see what role did community health centers, or have they played in your state in some of these partnerships? And then 2, what role does their model that really encompasses sort of that community outreach and enabling services, what role can it play in terms of the match that you all are referring to? Does it refer to that, or is that more of an avoided cost sharing approach?
I can quickly, I would encourage folks, just yesterday New York received $99.9 million from CMMI for their SIM grant, and it's all about advanced primary care. Okay. And that really details nicely how we intend primary care to really be part of the system in ways that they haven't traditionally been. I think that's a very nice detailed answer to your question.
So I can address it in Boston. The community health centers are part of our integrated health delivery system. We have about a dozen health centers in a corporation called Boston Health Net. That is the delivery system along with primary care at the hospital campus. So everything we do as a system includes the health centers in the neighborhoods in our catchment area. But if I could comment a little bit, I'll just circle back to behavioral health, a couple of comments. One, clearly, that was probably the one area where we were mandated by the state and CMS that they wanted integration of behavioral health, even though, as I mentioned, they were hospital, driven from the bottom up projects, that there would be integration in primary care for behavioral health and primary care. And that's both in our original DSRIP and what we have on the table now for the continuation. But in a different context, I think some of the questions about these other agencies and programs and how do they work in DSRIP or DSTI, I think Massachusetts, we look at it differently. It's not so much being looked at in the DSRIP or DSRIP project. It's sort of in where the state's going with its Medicaid program. DSRIP is seen as a rather smaller piece, and they're working towards Medicaid ACOs, in which ACOs will form, including hospital providers and mental health providers and community health centers, together as the ACO, accountable for the care, and you need all of those services, and you will be rewarded for the higher quality and financially rewarded for appropriate lower care. So that is the sort of the lens the state's looking at changing the system and not forcing it through the DSRIP program, although the DSRIP program is seen as a setup for that piece. So I think it's a different kind of view or different sequencing perhaps in some of the other states.
Regrettably, Texas didn't include FQHCs in the waiver. It was an oversight, and I think as a result missed the value proposition that FQs can offer, particularly around readmissions. When you have the community health, it's a community health worker that really is key to a whole lot of this stuff. And what happened, I think, as a result is there's been an investment made in community health, but it was already there with the FQHC. So I think in retrospect that was a mistake that probably will be rectified in the renewal.
Okay, thanks.
Yeah, this is Dave Kiefer from SEIU UHW. Could you say more about how you overcame the resistance that I would imagine is there with public hospitals being the source of IGTs, and now you invented a waiver process that it draws the private sector in, draws in other provider communities. How does that work so you don't end up with essentially a food fight? And because I can see that's one of our tensions in this state.
Well, I can't say you won't have a food fight, and I hope I didn't oversimplify it, but the culture in Texas was very different. I think we're starting in a very different place where the hospital financing mechanism was already dependent. There's about 6 public hospitals, hospital districts in Texas that traditionally have funded through IGT, UPL and DISH for a large part of the other hospitals, and there are a number of hospitals that benefit from those relationships. So we had already had that kind of relationship already. I think the value proposition in the waiver is that understanding that the burden that the private hospitals, private safety net hospitals, are taking on taking from the publics and treating more of the clients that they might be serving independently allows for additional dollars to be freed up to fund DSRIP. So I think that kind of serves as the value proposition. But there has to be a value proposition there, otherwise a public hospital couldn't do it. They have a fiduciary responsibility to manage the taxpayer dollars in a wise way.
But that's a good point. Public hospitals are there because they're mission driven. When I worked at Bellevue, it was because of the patient population I could serve. I was there for a reason. It's not all about the money. It's not all about the 4 walls. It's really about what we can do to help our patients. And when you start, the tension has been, how do you get to systems ahead of institutions? And if you can articulate the vision well about what you're trying to achieve and see how the system, maybe you don't have the exact same job, maybe there's more jobs in community health workers, there's more outpatient jobs, but over time, we were able to work with our labor partners to say, this is a broader vision, it's about a different pie. We will invest in workforce retraining. We will work with everyone to make sure that no one gets left behind, because the vision we articulate is so important. And I think that systems level thinking, the CEO who says, I have a fiduciary responsibility to my institution, well, you have a bigger responsibility to your community. And that's what really drives them to think broadly and understand that someone will help them at the end of the day.
Chris Brown with California Healthcare Foundation. Ron, 2 questions for you along very different lines. The first is, I'm curious how far you're taking this notion of interdependence and whether or not what you're building toward is almost like an ACO, that each of these regions would become an ACO and they would be interdependent not just for the DSRIP-like dollars, but for the broader Medicaid dollars.
I think you're right. So, okay, let me answer the first. So, I don't think ACOs are enough. I think of ACOs as shotgun marriages of convenience. I think they're still trying to do business as usual, and to the extent that that'll get you so far, it's not going to get you what you really need to transform the system. When you can actually create a nursing home that doesn't send patients to the hospital every Friday night when they're understaffed because it's the right thing to do, that's going to be the level of transformation. And that's a very bad example, but there's levels of transformation beyond what we think of as an ACO that are going to be necessary to achieve what we need. And that's what we're aiming at. When we talk about in New York the end of the AIDS epidemic, that's transformative. By 2019, it's going to take a whole different set of skills to achieve that kind of partnership with the AIDS outreach worker who knows where the homeless AIDS patient sleeps under the bridge to the hospital, all working in real time together for the outcome of ending AIDS, right? That's a very different conversation than I won't send patients on Friday nights, or I'll send fewer patients on Friday.
Okay, so the second question, I suppose this actually isn't unique to, a question that's unique, specific to New York, but I'm curious about this, the topic of services that aren't traditionally covered by Medicaid or federally matched by Medicaid, in particular housing, because you've mentioned housing, and I'm wondering if the DSRIP-like programs, because I thought I heard you say you were trying to address supportive housing,
yeah.
But I thought specifically CMS said no, we don't match.
No. So this is state share only dollars. This is not part of DSRIP. This is us out of general fund dollars saying, okay, we know that we can't afford not to do supportive housing, and folks at CMS get it. You know, they're just worried about how do you allow supportive housing without letting yet another runaway government spending program grow and the optics associated with that. They're willing to pay for bricks and mortar if you call it a nursing home, right? They'll eventually, I mean, they've figured it out that they've got to do this, and there's many states who've talked to them about this, but we know we need to do it.
So in approving the DSRIP, they appreciate that has to be a part of getting to where you need to go, but they won't support it with it.
That's right.
Got it. Thanks.
Cindy Enos. Thank you. And my question is, how have your states considered the changing role and relationship of the Medicaid managed care health plans to these provider system transformations? For example, things like pay-for-performance systems that, again, aren't so piecemeal from one health plan doing it, another one in the same delivery area not doing it, that they prove to be unsustainable over time. Have you considered changing that role and what that dynamic is?
I can start. Massachusetts, actually Boston Medical Center runs the largest Medicaid plan in the state. It's about 350,000 low-income folks in the plan, most of them Massachusetts Medicaid, though the program doesn't directly relate to the DSRIP program. It's individual, but it does absolutely relate to where the state wants to go with ACOs and what is the future of the Medicaid program, and that is clearly on the table. Our program is probably 60% MMCO and 40% or so PCP based. And the state has said they want to move away from fee-for-service, and they consider the MCOs basically fee-for-service underneath that. So either the MCOs could go and share that risk with the providers, and so they wouldn't be fighting the provider system for, you know, a volume reward game. But it's not clear. We do have a new administration coming in, and I think that for us will be central. Where does the entire Medicaid program go vis-a-vis managed care or ACOs, or probably both in reality, and sort of, or how does the expertise that exists in the MMCOs assist these fledgling ACOs, most of which don't understand managed care. You might if you're a system like ours that has a managed care plan, but many don't. So how do they marry that up? How do they take that intelligence that exists in the insurance company side that looks at the total medical spend and not filling the beds or a volume incentive program? So it's got a way to go, but I think it will be worked out before the next wave, or in how does it fit in the big role. Again, I think DSRIP, or in our case DSTI, is a smaller piece of that as opposed to the central part around figuring out the role of managed care or moving into an ACO model to bring all the right providers to get to the right health outcomes and population health with whichever geography is served by that ACO.
In Texas, we put 4% of the managed care premium at risk based on a couple of performance measures, 3 of which are predictable hospital admissions, readmissions, and ED visits. What that creates below the MCO, at the MCO level in the network, is to create gain sharing agreements with the network providers who can then help them reduce those inappropriate admissions and work on readmissions. The piece that has been missing that Texas is now working on is to align the waivers similarly so that everybody's got that synergy and they're all moving to the same direction. And then below that, as Peter said, one person can't do that, one entity can't. So it starts those collaborations and the gain sharing agreements and all those kinds of things that I wouldn't call it an ACO, but it starts building more accountable care within the organization.
And just briefly, in New York, it absolutely is fundamental as a strategy to get to 90% value-based payments, which mean not just the state paying a rate and then fee-for-service goes on as usual underneath that to the providers, but really teaching providers to swim in the deep end of the risk pool. For providers who bring a very different set of population health management tools than insurance companies who bring a very different set of tools based on different data, to really work together, to share that data in real time, to collaborate and partner in ways that only if both are at the table can you really achieve the outcomes you need.
So I have a question. I run an FQHC in California, and we have a CMMI grant. We're in our third year. And one of the things, we have partners that are not medical partners. So we have a recovery program that's doing RAP, and so it's recovery support, and another organization that has community health workers. And our biggest issue is HIPAA, because they can't look at our EHR. And we spent a lot of time trying to create a way of communicating, wasted a lot of time in the grant process, and are just being able to collect data in the third year that's meaningful. And so have you thought through that, and how are you going to do that when you add all these other social service agencies that you can't have a HIPAA business agreement with like you can a medical facility?
Briefly, in New York, we were lucky to have a very strong infrastructure of health IT, RIOs that connected, and as of April, we funded at the state level with state dollars one statewide health information network, New York, marrying all of the RIOs together. So suddenly the data becomes not an insurance company's data or a hospital's data or an individual RIO, but your data as a citizen of New York, because it's taxpayer dollars. And so that allows us to rethink how data flows fundamentally. It's going to be all Blue Button Plus, so anyone can get all of their data in real time anywhere on any device. You can consent across the system. These are places where the state can step up and play a role because it's really hard to reinvent it every single time at the local level.
Good morning, Bill Barcelona with CAPG. I think all of you mentioned a transition in most of your states to capitated payment. Why do you believe that CMS is so interested in moving to a capitated payment system?
Well, I think in the ACA, around in the Medicare program, for sure, they're moving in the MSSP program and the Pioneer program. I think because it seems to me a viable hypothesis on how to bring costs down, to get away from the fee-for-service. Certainly that's the direction the state of Massachusetts wants to go on, to attempt to tackle cost concerns. Although we're proud of the high uninsurance rate, I think we're the highest expensive state in the expense side, so we have a lot of movement. And fee-for-service hadn't worked. So it's basically that it seems, the per capita is to look at the total medical spend of the person and look at it in totality, like an insurance company does, as opposed to just individual providers.
Yeah, I think we're going to be in a world within 3 years, maybe 5 years, where total cost of care drives a lot of decisions, where we will have that level of transparency. And if you look at the most successful Pioneer ACO, Montefiore Medical Center, 80% of their dollars are Medicare or Medicaid. They're doing very well, let me put it that way. Capitating, they are able to invest and start school-based health clinics because they can tell you to the number how many pediatric asthma admissions that will prevent, how many teenage pregnancies that will prevent. So the local knowledge that's fundamental to transformation only happens if you're allowed to make those decisions under a capitated or somewhat generous environment.
Hi, Barbara Hanna with Home and Healthcare Management, and I'm also a graduate PhD grad student at UC Davis School of Nursing. Can the group speak to the role of home health agencies and hospices with the risk pool particularly? I'd like to have examples of how that was structured with these type of entities. It kind of goes along with the social services, the social determinants of healthcare, and has any of the plans utilized home health agencies in a role of care coordination, transitional care, instead of looking at the traditional discharge planning mechanism?
I can give you one real example. Maimonides Medical Center, for example, has done that, and they're able to, with an army of community health workers, intervene and push things upstream and show in real time how a parallel problem list, not the medical problem list, but the social non-medical problem list, focusing on that with folks who understand the community and the resources available in the community can really change the trajectory and reduce total cost of care. And I can connect you to those folks if you're interested.
Thank you.
Richard?
Richard Thomas and Blue Shield of California Foundation. As California succeeds in enrolling now over 11.3 million folks in our Medi-Cal program, the question of access becomes more and more front and center for a lot of us. So I'm wondering if you could talk about how in your DSRIPs you've been using elements of incentivizing team-based care in primary care settings and empowering community health workers that were just mentioned or frontline workers to take off some of the tasks for primary care providers, and how much that's been a success for you.
I could say, as part of looking at integrating the behavioral health into primary care, definitely we are looking at in a lot of the projects around reinventing the primary care to take some of the burden off the clinicians and at the lower levels to do that, to expand access. Perhaps we don't have as big an access issue in Massachusetts because reaching the full coverage, we've actually done it over 20 years and not so much just in this waiver, so it's been more gradual. So it's not acute, but there are some shortages. And as we've recently increased, looking to expand primary care capacity by bringing other folks into the medical practice, be it social workers or nurses or extenders to do that. So there is some revising the programs, and those are some of the projects both at Boston Medical Center and some of the smaller hospitals.
I think it's a little bit early yet in Texas. We're in our third year now. But what I've seen is the system's becoming more efficient. And so you're going to have better access based on some increased efficiency. It takes a long time to develop a provider. There's an opportunity, I think, in DSRIP waivers to develop residency programs and those kinds of things. But ultimately, the short term has been more efficiency in the way that services are delivered.
And we just committed to patient-centered medical homes. We said you will get paid this if you're a level 1, you'll get paid this much more. If you're a level 2, you'll get paid this much more. If you're a level 3 and CQA patient-centered medical home. And that worked really well.
Anthony? Anthony Wright from Health Access. Thank you, Richard, for that question. So I'll ask another one, which is just to take off from my colleague that asked earlier, but to the different states and also to Peter on other states, which is about community and consumer involvement in the process. Both of just what was the how did in your different states involve consumer patient constituencies in the development and in the negotiations with CMS? What did CMS require, and what kind of requirements or standards do you have for when the post negotiation phase when developing the specific projects in the ground and involving patients, or when we're talking about regional health, the public in general?
I would say direct involvement, not a lot of direct consumer or individual involvement. It's pretty much inside baseball and difficult to follow. Of course, there are the public processes mandated by CMS in the public meetings, and they're available. But there are active groups like in Massachusetts, Healthcare for All, which is a good proxy, represents the community interest and follows it in detail, and they have a pretty sophisticated group for the waiver. Outside the waiver in the ACO, both in the Medicare program and in the boards of those ACOs mandate a consumer on those, and Massachusetts will similarly take that up when we move to Medicaid ACO. So there's some direct involvement in the governance of these organizations as they're being set up. but not so much directly in the waiver negotiations or following the detail of it.
I think there was actually a lot of help from consumers and from SEIU and other partners in achieving our vision of the waiver. You know, we'd have conversations and then someone else would call the White House for us and follow that up. And so I think that that really did help us move. It took 18 months. It would have taken longer if that didn't happen.
And on the ground in both Texas and New York, you did have this extensive community needs assessment process that's been done. And so that involved not only data analysis in all the different regions, but a lot of qualitative interviews, a lot of stakeholder input, really asking the community what's needed out of DSRIP, what changes are needed, how can the health system be better. And so when the New York applications come out, you're going to find all of them have extensive 100, 200-page community needs assessment documents where the community really was involved in defining the problem to the extent that people are included in defining the solution. That's going to be up to each individual, regional group and what they actually did. But there was a lot of input that was gathered from the community in terms of defining the problem in New York anyway. And I think in Texas you had the same process. So it's about 12:15. Do we have, we'll take one more question. If there's one more question, though, it's never bad giving Anthony the last question.
Hope this is a small question, but has anybody, what has been the role of transportation or transportation providers in some of yours? Because it's probably, in our national needs assessment, it's always number 2, number 3 barrier to care in healthcare. And if it's a barrier to care for health care, it's also a barrier for some of the other social determinants of health. And so it's we've seen some health centers that have invested it on their own money, and anyway, so I'm just wondering where transportation has fit in there.
Yeah. I'd say in our 12-dozen health center network, we have buses that circle through the city a couple of times a day. So we have transportation paid for out of the hospital system, but it wasn't directly funded out of the waiver. But it's like a couple of 100,000 transports per year, so a lot of volume.
With that, we're going to go ahead and break for lunch. We have 20 minutes for lunch here in the room. Please, thank you. Join me in thanking our panelists. And when we come back, we'll have Erica Murray and Dr. Neil Klotz, who are going to kick us off for the California panel.
We wanted to get there anyway.